Okay.
Yeah, high video panel and high flow immunity controls.
All right, perfect. So thanks for joining us for surgery grand rounds at Phoenix Children's Hospital. I'm really happy that our speaker today, Dr. Amod Sawardekar, agreed to speak. So he's the Director of Perioperative Services across our whole enterprise and the Associate Division Chief of Anesthesia. And a couple of years ago, he was recruited here by Dr. Osley, Dr. Munzer, and Mr. Meyer to, along with Sim, Jag, and Nathan, to kind of build our anesthesia services here. They were able to recruit our unbelievably talented group of pediatric anesthesiologists that we were sort of taking for granted, but we really wanted to keep all of them, which they did. And they've really built their department now from the ground up. So his mission-driven dedication and his very calm and sort of calm demeanor and dry sense of humor have been key, I would say, in developing these services across the city. He did his training at Rush University and his pediatric anesthesia fellowship at Children's Memorial in Northwestern in Chicago, and then was working at Lurie Children's when we recruited him. He also obtained an MBA from the University of Tennessee, and his research interests are in the area of pain management, regional pain care delivery, and complex airway care. So I've been very grateful for his collaborative nature, his innovative spirit since arriving to Phoenix Children's. He's going to, oh, by the way, I asked him if there's any fun facts about him, and he said no. I'm sure there are, so I was going to make some up that he's like that he was like an Olympic snowboarder before coming here, so you can ask him about that. But he's going to enlighten us today on the workforce challenges by pediatric anesthesiologists across the country. So warm welcome to Dr. Sawardekar.
Thank you, Kathy, for the introduction. And, so I'm going to be talking about anesthesia workforce and imbalances. And as I look out to the audience, and likely online, there are, most of you are not anesthesiologists here. So this is meant to be casual. Feel free to interrupt me if you have questions on anything. I have no disclosures. My goals here are really to share information with everyone on what the pediatric anesthesia workforce is today, the history on how we got here, and where we're going from here. And also looking at solutions that may fit not just our institution, but many other institutions that are likely coming down the pipeline with what we see here. And so I'm going to start out with just talking about physician shortages, because obviously in the world of capitalism, we'd like to have our supply and demand sides be roughly equaled out. And we know the market forces oftentimes force that equalization by incentives provided by capitalism. And when it comes to physicians, that type of capitalistic forces tend not to really be as pertinent because of the length of training that we all have to get to our final state. And so before, delving into the anesthesia specific nature of this, just going through, this is something that probably everybody in this room is affected by. There are shortages everywhere. This is a headline from Time Magazine on physician shortages. There's headlines from, this is the ACS, CNN, you name it. And there are so many headlines that come across on what the current state of physician shortages, what the future state of physician shortages, and it's pretty bleak, and it's going to impact all of us in many different ways. But I'm going to get into the anesthesia specific nature of this as well. So we have over 50,000 anesthesiologists in the country that are at least registered. We think that there's around 45,000 that are practicing. There's over 50,000 certified nurse anesthetists as well. And the AAMC has predicted that there's going to be a pretty significant shortfall of physicians, about 12,500. So that would mean that we would need to increase our workforce by pretty significant margins, by over 30% to get to that need. And getting there is going to be a challenge. We know that just looking at some of the stats are in this peri-COVID, post-COVID area, we lost a large portion, 6-7% of our workforce was lost to COVID attrition, which was second only to pediatrics in sheer number. Not only that, right now we know that a significant portion of our workforce is over the age of 55. Now, I think in some part that is an exceptional stat because that means we have a body of anesthesiologists that are clinically active, they have expertise, they are well seasoned. But in the same lens, we have to take a practical, pragmatic approach to say, this is gonna lead to probably natural attrition to retirement in the next decade and a half for many of our specialties. So we're looking at a need of 12,500 and taking into account a really pretty significant attrition that's coming up. And all of this has led to a pretty significant increase in applications into anesthesia. We match 100% of our candidates. There's several candidates that go unmatched now, which was a very different story from years past, which I'll also get into in a little while.
You're saying that the anesthesia residencies aren't getting enough applicants, or the applicants don't have enough, that wanted anesthesia don't have enough spots?
There's a huge interest in anesthesia currently. And there's about 1,600 anesthesia residency spots per year, and they're all getting filled right now, which was in stark contrast to just a couple decades ago. I want to take a moment here just to talk about nurse anesthetists, and they really occupy the vast majority of care that happens out in the rural areas. So it's about 80% of anesthesia providers by the stats are in rural counties are nurse anesthetists. And so living in Phoenix, being in a metropolitan area, we don't see this as much. But once you get out into the periphery, it's very hard to recruit physicians. And so nurse anesthetists certainly play a role in providing anesthesia care. And they're also likely to have a pretty significant shortfall of staffing as well. So this is a study that was done by Matt Muffley. He's out of Stanford, a very interesting guy. He looked at the stats from essentially 2000 to 2015. And his goal was, what is the state of pediatric anesthesia? And he published this in 2018, which is a little while ago, but I think it serves as an important context. And looking at it, he saw that the number of pediatric anesthesia fellowship spots in 2000 were around 60 spots a year. And in 2015, that had ballooned out to over 200 spots, more than a threefold increase. And it was very popular. People really wanted to go into pediatric anesthesia. It was a very popular fellowship to do amongst anesthesiology residency graduates. And there were programs coming up all over the place. Any place that could train, were training. And his conclusion was that there's a plateauing of pediatric anesthesia clinical volume. We have a proliferation of training programs. This is going to lead to this oversupply of pediatric anesthesiologists. And it's really in the face of a plateauing demand. And so this article has sounded an alarm bell of sorts. And this was published in 2018. And, it just, as soon as that happened, you saw all of the student doctor networks, the Reddit forums, they're all popping up on medical students to say, wait a second, there's this am I going to have a job if I'm a pediatric anesthesiologist? And for at least here in the room, it's a younger crowd, but anesthesia, this is very reminiscent of anesthesiology in the 1990s. Not that I was practicing then, but in 1995, there was a Wall Street Journal article. It was on the front page of the Wall Street Journal article, and it outlined in a lot of detail how there was a graduate from UCSF, from an anesthesiology residency program. He did an advanced training in cardiac anesthesia, and he couldn't find a job. It detailed how he went to 10 different hospitals in the California area, driving 100 miles routinely just to work 5, 6, 7 days a month. And after all of that, he wasn't even making $100,000, which even in 1990, it was a struggle because almost everybody else in all the other specialties were making as much or more than him in the mid-1990s. That single article led to the demise of interest in anesthesiology. And for really the next 8 or 10 years, anesthesiology residencies never filled. And so coming now full circle to, what it is now with a very strong demand, huge interest in anesthesia from medical students. this article dropped in 2018, and this kind of sunk interest in pediatric anesthesia from anesthesiology residency graduates. And that's in fact, now, again, Matt Muffley, again, is a senior author on this paper that was published this year. And, you know, he's a very nice, really goofy guy, and he admits, he's like, this article was really revolutionary in trying to predict what our staffing needs was, but I just got it all wrong, okay? So he basically said that there is such a strong interest in anesthesiology training, and yes, COVID got mixed into here, but there was nobody interested in pediatric anesthesia anymore. And yet the demand, the clinical demand, actually, he got that all wrong. He said, I thought it was gonna plateau, but no, there was demand from all directions. Pediatric care kind of exploded, and there was care that was happening at children's hospitals across the country that weren't asking anesthesia services that now are asking for anesthesia to be involved in 2024. So now we have a huge demand and not enough supply, and this is the imbalance that I'm here to talk to you about today. So what is a fellowship? It's only a 1-year fellowship. There's very, very little interest in it, and we're hoping, at least as a pediatric anesthesia community, to stir up interest in this at even a medical student level. Here are some stats. You can see this goes back to 2000. The top line in blue is the number of residents in anesthesia in total, and you can see that that has steadily gone up over the last 25 years or so. And at that time, there was only 3 fellowships that you could do in anesthesia, which was critical care medicine, pain medicine, and pediatric anesthesia. And anesthesia, you know, critical care has never been a fellowship that had a strong interest base, but you can see here it's the light blue line at the bottom, but even that has kind of increased up. The pain fellowship has gone pretty much in accordance with the number of anesthesia residents. That's the brownish line that's just below the residency line. And then the yellow, the mustard line there is pediatric anesthesia. You can see it it was increasing pretty significantly up until 2015, and then it plateaus off. And now you can see we're the one with the downturn line here. And again, this is just another depiction of this. In 2001, there was only 3 fellowships. The yellow area is the percentage of residencies, residents that were going into pediatric anesthesia, and that hasn't really changed in the last couple of decades at all. And you can see all the proliferation of all these other fellowships, OB fellowship, regional fellowship, and whatnot, that has really increased in interest from the trainees' perspective. This is another stat on looking at the number of pediatric anesthesia programs that are out there, the ones that are filled, which is in blue, and the ones that are unfilled, which are in red. And in 2018, you can see, you know, the number of filled programs are roughly twice the number of unfilled programs. And then fast forward 6 years, 2024, it's actually now flipped. So very few programs filled today. Most of them go unfilled. We have recently transitioned to the San Francisco match from NRMP. And there is a quadri of anesthesia residents that actually don't apply. They don't even engage in the match because they know that the day after match, post-match day, there's going to be 2/3 of programs that are going to be open, and they can simply call the program director and say, I want to go to come to your fellowship. And more likely than not, they're qualified candidates. They will be accepted, and they don't have to go through the whole process of the Zoom interviews and whatnot. They can pick exactly where they want to go based on the availability of programs. Another depiction on even the number of enrolled fellows. Again, yellow line is in peds, and you can see a pretty swift decline here in the last couple of years, with really plateauing in the last 4 or 5 years in interest in anesthesia. In 2022, again, out of all the programs, 2/3 went unfilled. The number of positions filled were 137 out of 215. In 2023, not much better. In fact, it got a little worse, 125 positions that are filled. So I'm kind of articulating a story that we're only producing 125 pediatric anesthesiologists a year. And you can imagine there are all these factors that are taking anesthesiologists out of the workforce, including retirement, attrition to adult fields. and a few other things that we're gonna talk about, but we have 1,600 residents and only 125 are going into pediatric anesthesia. And so kind of begs the question from our community of pediatric anesthesiologists to say, what's up? Why are we here? And oftentimes it's in anesthesiology, the one thing that provides dissatisfaction to our new graduates is a lack of autonomy of their schedule. They are very much at the whim of what the OR schedule is, what the procedural schedule is. And many of them are turning to locums jobs, which offer them a fixed time period. I can work from this hour to this hour. I can work on this day. I can be off on this day. It really shifts the autonomy to them to decide when they want to work. They want to have flexibility in their jobs. And with this shortage, obviously compensation has changed. And that's really led to a lot of, challenges in fellowships and advanced training in general. Post-COVID, with this attrition of physicians, there's been a huge demand in the adult world. And we've seen new graduates get lured into jobs or locums positions because of the increased compensation. And they don't want to forego the opportunity cost of training for even one additional year. And so you can see, compensation has increased across the board from adult counterparts and pediatric anesthesia included, but pediatric anesthesiologists oftentimes were remunerated less than their adult colleagues for many years. And now that has slowly shifted with the absolute shortage of pediatric anesthesiologists, which is a good thing for us in trying to help recruit physicians. But ultimately, the demand for our services has increased pretty significantly as well. And something that I alluded to earlier, children's hospitals have had, at least in anesthesia, we call it NORA, which is non-operating room anesthesia. And this could be for GI cases, this could be for medical imaging, this could be for dental cases, but we've seen a real consolidation of care in this country, and Phoenix included, where many children's hospitals have seen a lot of growth, mainly from consolidation of adult hospitals providing care and seeing these adult hospitals close their pediatric wings, closing or limiting their offering of pediatric services and have more consolidated care in children's hospitals. And at least from our lens, we have seen a pretty significant increase, including in medical imaging and procedural areas outside of the operating. So what does that mean? Ultimately, we're talking about the supply and the demand. And, I have Sim on one side saying, these are the number of anesthesiologists we have. We have physicians that retire. We have physicians that are leaving to do locums or doing maybe adult work that they're getting compensated for. We have fewer people going into pediatric anesthesia. And then on the other side, I have Dr. Osley, like, hey, I have all these opportunities for all of your doctors. Like, what else can we do? And now I'm thinking I should have put Jared on top, being like, can we figure this out? And that's where we're at right now. We're trying to figure it out right now because we have a real disparity in what we can provide and how we can provide it. So some solutions. At least on a very macroscopic level, it's how can we expand anesthesia residency programs? We know that there's going to be a shortage. We know that there's continuous expansion, but there's a limited number of hospitals that offer training. More specifically, it's like, how can we then transition residents in anesthesia to go into pediatric anesthesia? How can we engage our community of general anesthesiology trainees into pediatric anesthesia? And how can then how can we create this environment that really recruits and retains people to want to come into pediatric care? And at least in, for everybody in this room, oftentimes pediatric care self-selects out individuals. We like to walk into children's hospitals. People are happy here. They like to come in and be around people who have also chosen to be here, more generally happier than our adult counterparts. At least I like to think so. And we never had to worry about this in the past because we always had such a great environment and culture to be in. But I think it takes more than that now, for at least from my perspective, and looking at pediatric anesthesiologists. So we try to create a flexible work environment for our younger or newer colleagues that cater to what they're looking for, creating a flexible work schedule, offering mentorship helping empower our individuals for more autonomy and making decisions that impact their work life. And providing good collegial partnerships across the hospital. All of this is to say, we want to be a workplace of choice. And just to illustrate out a little bit of the history here at Phoenix Children's, in 2022, Envision was a primary provider of anesthesia services here. And in December of 2022, Phoenix Children's then acquired the 39 physicians from Envision to provide care and to be employed by Phoenix Children's.
Is Envision just the new name for Valley Anesthesia?
Correct, yes. So Envision was essentially a private equity anesthesia group that had, I think through several acquisitions, or prior to 2015, they were Valley.
Okay.
And since then, we have hired an additional 20 anesthesiologists. We've lost 2 anesthesiologists in the process. So by the end of the year, we will be at 57 physicians. We've obviously opened West Valley, and we're hoping to open East Valley, but that is another question. So what do we do here? Obviously we're in all of the operating rooms. We're in all of the procedural rooms, cardiac cath lab, the IR suite, medical imaging, nuclear med, PET, CT. And then we obviously, for those of you on the floor, we run the acute pain service. We have a chronic pain service, and we're part of the trauma response team as well. But looking at it a little bit more, the first 2 columns on the left are all the specialties that we are routinely providing anesthesia for their cases and for those kids that need it. And you can see it's a pretty wide footprint. And on the right, you can see all of the other areas, code team, airways, going to be PICU, NICU, ICU cases that we see. And we are a service line, and I think this is where it differentiates a little bit from some of the other physician shortages. So if you're short an ENT surgeon or a pediatric endocrinologist, that means that those clinic days aren't filled. And you're not providing that service to the community, and it may be taken care of elsewhere in the community. But as a service line, if your ENT surgeons are all filled and your medical imaging suites are all running, and I don't have enough anesthesiologists, well, then those are patients that aren't being taken care of in the community. They're our patients. They're coming here and they can't get their surgery or they can't get their imaging because we don't have anesthesiologists. And I don't know if any of you are probably reading some of the headlines, but the dock workers went on strike last night. And no one thinks about dock workers. I'm sure a year ago, if I asked you hey, are you concerned about dock workers? You can be like, what are you talking about, Amod? But now when you want to go shopping and Christmas is coming around and there's no toys on the shelves because they're stuck at a port because the dock workers aren't unloading those crates, or you can't get your shampoo, or you can't go to Home Depot and get whatever supplies you are from your home, everyone's talking about dock workers. And not to say that we're that granular of a service line, but if you can't get a medical imaging study because our team doesn't have enough anesthesiologists, people start talking about us. And we don't want that attention. We want the other attention about how we're providing great service to our chronic pain patients or our acute pain patients out there. And so as a service line, when we see a shortage, oftentimes that leads to a lot of negative sentiment around the hospital. And a part of today is I want to ensure everybody, we are working in the background. Our physicians are working very hard and they're extremely dedicated to our patients. And we are always trying to find solutions for this, for the way that we can provide mission-driven care, which is taking care of all the patients who need our care. So what are some solutions here? And on the top, we have ways to, look at it on an operational basis for the demand for our services, which is sometimes controlling or restricting block time for procedurists and surgeons, or rescheduling cases from high demand times to low demand times. And, as I look out and I see a room full of surgeons, is exactly what you don't want to see, you don't want to hear, because what we're really doing is on really busy days, we're kind of trying to see if we can shift our volumes or shift cases to less busy days, which then allow us to ensure that the goal of the mission is served, which is taking care of all the patients that we need to. And on the bottom side, we're really looking at the supply side. How can we retain our current staff? How can we make sure our staff are still happy, even when they're overworked and they're tired? They know that they're providing exceptional care to our kids. We want to make sure we keep our staff, and we want to be able to recruit our staff. And all of that seems to make sense, and it's abstract in concept, but it really does need to happen on a very basic level. And so, you know, I think we've had a really exceptional team working from so many different angles to make this happen. And part of this is just communication, making sure everyone is aware of what's happening and trying to spread just the information of what the current situation is in the hospital with our team. I know some of myself have gone to several divisions over the last 2 years to at least talk to them about our staffing, to talk to them about you know, specific solutions that can work, and to really ask for some patience. And I think we're at a much better time now that we've hired so many anesthesiologists, and this is less of an issue, but it has been very much of a growth in the last 2 years. Last summer in 2023, the end result was that we ended up scheduling about 160 cases, which is still a fraction of the number of cases that we're doing, but we did reschedule cases. Thank you, Kathy. From very busy days to less busy days. We tried to reschedule to, you know, lower demand times where we knew we could cover. This was really in concert with the patients of our surgeons, the patients of our administrators, and the understanding of the system. And it's really big. The question is, can we improve our operational efficiency, not just during the time where we're short-staffed from an anesthesia standpoint, but looking at it through the lens of the hospital to say, are we using our resources most effectively? And how can we have operational improvements that then actually improve the care for patients and improve the lives of everybody involved and engaged? And that sometimes is a very challenging task, and it often is a process that's difficult for all. And when we come out on the other side, we can all benefit from improving the operational efficiencies. Okay, so other solutions. Really, you know, what I spoke to earlier is how can we improve flexibility for our physicians? And that means how can we allow our physicians to have some autonomy and some agency in their work lives? And that means that what we've tried to do is create a system that allows our physicians, in some ways, incentives and to work more. And if those individuals want to work less, they're able to do that, and to be able to offer that flexibility ultimately is what not just our physicians, but really the larger element of the anesthesia workforce wants, is helping gain a little bit more agency in their work life. And we believe that helps us retain many of our staff and improving their wellness. And ultimately, it's much easier to retain staff than it is to recruit staff. So after I, kind of told you that all of these fellowships are going unfilled and there's a whole lot of positions, well, we went and we started our own fellowship. So, on the right side, you can see a picture of the Southwestern US. Outside of California, there's only 3 other fellowships in this entire region. And so while there are a ton of fellowships out there that are getting unfilled, the vast majority of them are in the Northeast and Midwest. We really believe we have a very large volume of cases. And there's an extraordinary opportunity for teaching that can happen here. And so we put in our ACGME application roughly a year ago, last September. We got approved in February of 2024. We were very late to the match, but we did enter the match, in which we did match 2 candidates that will be starting in August of 2025. And so we're extraordinarily fortunate that we matched 2 fellows as a new program, and in the landscape of pediatric anesthesia, it's a pretty extraordinary thing. We have an excellent team. We have an excellent GME team. And a shout out to Barbara, who was in the audience, but I don't see her anymore. But she was instrumental in making this happen. Another shout out to our recruitment team. So the talent acquisition team here is phenomenal. Here's a picture of Reggie and Sim at one of our national meetings. But here, we're pretty aggressive with recruitment. We go to almost every meeting that we can. We advertise in the journal and social media. We generally actually go to between 6 to 8 fellowships across the country. And we reach out to their program director, their chair, and I would say almost every time, those individuals say, yeah, please come here. Our fellows need to find jobs. And we meet with them, we tell them about Phoenix Children's, we tell them about what we have here. And, some of them just, enjoy a nice dinner, a nice conversation. Oftentimes it's their first foray into looking at a job or even talking to leadership from a pediatric anesthesia group. So I think that's certainly been very engaging to meet a lot of younger colleagues. It's, I think, been refreshing on their end to be able to meet people and talk to leadership face to face. I think it's certainly been successful in helping us recruit the number of physicians that we have. And it's not just anesthesia in this perioperative space. We find that there are shortages in nursing staff in the periop space. It's a very different environment to be in the operating room. I would say it's a very collaborative environment, but there are certainly stressful times, there's challenging times. And it can be difficult to retain the periop staff, and that can be nurses, that can be surgical techs, that can be SPD, that can be other, other ancillary staff as well as some of our surgical colleagues who I know are oftentimes also short-staffed and overworked because they've lost colleagues. And so there are shortages all around us, and not to say it's just in the periop setting. For those of you that are outside of that, I'm sure on the medical side, there's disciplines that have had severe shortages for a very long period of time, and we all live in it and we all accommodate it, and we sort of get used to the additional work, but that's not to say that that's okay. I think that needs to be acknowledged. I think we still have to do things to ensure wellness, to ensure that our physicians and our clinical staff are taken care of, to ensure that we don't lose them as well. So in conclusion here, I just hopefully have articulated some of the pediatric anesthesia specific needs right now, how healthcare systems need to be integrated into the process, and we should be all collaborative with each other. Ultimately, our patients come here to get care. They don't come here necessarily to get taken care of by a pediatric anesthesiologist or or a pathologist. They come here to get their appendix taken out when it's needed or to get their fracture reduced. And our parents and our patients expect just the most exceptional care. And that requires us all to work as seamlessly as possible as a health system, not as a sole entity. So with that, I'll stop by, taking questions and just a reminder to do your QR code if you see it.
Can you comment on the regulatory and quality work that you're doing?
Sure, I have Dr. Hussein in the back, and I have Dr. Frazier. I think they're working on a relatively new team of quality and safety within the perioperative space. I think for many years, it was that, Dr. Hussein has worked on quality from the anesthesia lens for years. And I think now being part of PCMG, we're slowly trying to carve out more space, more time, more dedication in that. I think it's integral to at least our specialty. And we hope to be leaders in the perioperative space because we are in the operating room every single day. We work with, the collaboration of all of the procedural and surgical specialties here. And I think that it's really our duty, and I think we're well positioned to be leaders in the space. Dave, first, I saw your hand go up.
I mean, obviously, a different approach is the greater use of CRNAs needed. Allow limited number of dollars. Be able to cover more cases than 3,000 cases. Other work outside of the one. Just kind of wanted to get your sense of kind of what are the pros and cons of utilizing your AA and all of this.
Thanks, Dr. Desai. So, can everybody hear the question or do I need to? So the question was, from Dr. Desai, he came from Texas where they utilize CRNAs as well as AAs. And, what is their role in children's hospitals and, is there a potential benefit for using them or drawbacks? And my answer is such that I think that looking just statistically at the children's hospitals across the country, there are only 3 or 4 freestanding children's hospitals that are a physician-only anesthesia model, and we're by far the largest one. And certainly has its, the drawbacks are really in terms of limitation of services. And I think the benefits speak for themselves in that, you always have the expertise of the physician being engaged in enabling care. And most other facilities across the country utilize either AAs, which are anesthesia assistants, or certified nurse anesthetists, simply because they can't recruit physicians. I just articulated out how difficult it is to get physicians into a practice, and most places cannot hire enough physicians. Now, we've been very lucky, I think we've been very fortunate and to be able to recruit physicians here, to recruit highly qualified and highly skilled physicians. And I think if other children's hospitals could do the same, they would probably move to this model as well. So certainly, if it comes to the point of limitation of services, I think you have to entertain whatever resources that you have available to you. Ultimately, looking not just at Phoenix Children's, but looking very macroscopically at children's healthcare across the continuum of the United States. The fact that if we've recruited 20 anesthesiologists over the last year and a half, that means that these 20 anesthesiologists are not providing care elsewhere. And it's ultimately a zero-sum game. If we recruit somebody, that means they're not working at somewhere else. And that means they're going to be short-staffed, and that means that they're more likely to hire nurse anesthetists or anesthesia assistants to provide that flexibility. So as long as we can successfully recruit, I think that we have the benefit of always having a physician in the room. I think probably at your old practice, when you're having an anesthesiologist supervise maybe 2 or 3 nurse anesthetists or AAs, you've probably been in the situation where you're looking to say, hey, I'm running into some challenges surgically. I need some help from my colleagues across the curtain. And you look over and you say, okay, well, can you make sure the anesthesiologist is here? And they're calling and you're waiting. And I can guarantee you that never happens here. And I think that's the real benefit, is that you always have that reliable, you have the end user with the most expertise always available to you. So certainly there's a role for it. We've been able to largely avoid it by successfully recruiting.
So first of all, this is great talk. In the last 20 years, I've never heard someone talk about this. And it's a looming problem, right? So I think it's great that you're acknowledging it happened. And one of the things I really wondered about over the last year specifically is when you choose to enter into a pediatric subspecialty, you are deliberately restricting the job opportunity. It's a deliberate conscious choice. You can't practice anywhere. I can't, I'm a pediatric neurosurgeon. I love my patient. I can't live in Montana. That's not an option. I can't give pediatric. I have to live in metro area. And so when you think about that, the workforce challenges, I wonder a lot about how to tackle that piece, which is most people go to peds, want to do peds, they don't want to do hybrid, they don't want to take your animals, and you need to live in a place where it's certain mass of pediatric patients. The more suspect want to do that, like my colleagues here, the more restricted your job choices. I think that's issue number 1. Issue number 2 is generational change. We have a lot of very young people here in the audience, and I think the young physicians value things that are a little bit different, are willing to make different choices than the older, I'm not old. They're older physicians. And I really struggle how to tackle that, because it's like, we're recruiting now for pediatric neurosurgeons. And people are not willing to stay there anymore. They're not willing to move 10 times, you know, they want to do fellowship, they want to stay. Where they use that, you know, a lot of people have kids now, and for pretty much training paradigms, and people don't work life. And so I struggle with all of these things. I think that there's a cultural component that's in addition to the economic. How do we tackle it?
Excellent points. For those of you online, Dr. Upman was illustrating one that as pediatric subspecialists, we are self-selecting and we're narrowing down our job opportunities and job potentials. And went on to then describe generational differences in what our workplace expectations are. And combining the two, how do we look at this from a global perspective and try to tackle it? And it's a challenge that we're all facing. You're right. It's almost this conglomeration of challenges all coming at us all at once. And I will tell you, it's very exciting to be here because, you know, looking at the process we have to go through to get a pediatric anesthesia fellowship here, I will tell you, you know, the GME team here is phenomenal. And I'm, you know, in talking to them, it's like we've done this so many times so frequently. And I think one of the solutions is to have our own training programs for the reasons you just talked about. If we have our own training programs, it allows us to recruit physicians here to undergo their subspecialty training, to spend more time here. That's probably our best advertisement in terms of helping recruit our future workforce to help keep them here. And we have to listen to them. I mean, there's no doubt about it. I think workplaces have always been intergenerational. They've had different aspects, different demands. And I think it's important to be transparent with expectations, but also to be flexible and to be understanding and to be a workplace of choice by listening to everybody that's in your workforce and knowing that everybody's not going to get everything, but most people will get something. And I think that's at least a concept that, you know, people can get behind for the most part. But I think a great first step is just having our training programs here. And that in and of itself, I'm a big proponent for is, you know, that's our legacy. I think many of us that have been in medical education, it's extraordinarily rewarding to, you know, see an old trainee and then they kind of update you on what they've been doing, and they always, and when they do reflect positively back, it's a very, you know, self-fulfilling thing for those of us in GM. So, you know, maybe it's selfish, but I think that GME training and having additional options for medical education is one potential solution for that.
Thank you for the thought. In general surgery, you know, it's become more specialized and result training has gotten longer and longer. They've developed hybrid programs. So is 3 years of general anesthesia training still necessary if you're going to be very specialized as a pediatric anesthesiologist? Is there a way that you could truncate the general anesthesia training and augment it fellowship?
So Dr. Padilla's question was, is there an opportunity for hybrid training to allow for either shortened training and residency to expand fellowship opportunities to make it more palatable to go into it, or are there other solutions? That's actively being discussed right now. Pediatric anesthesia is required for 2 months out of your anesthesia training, out of 36 months of training plus your year of intern year. Only 2 months are dedicated to pediatric anesthesia. So there is an active discussion going on right now whether pediatric anesthesia should be expanded in the general anesthesia training program, which would allow further expertise, really to allow general anesthesiologists to have more comfort in providing anesthesia care in the pediatric space at really community hospitals. So if they go out into the periphery, they can take care of the 8-year-olds and the 12-year-olds and the 14-year-olds that are coming in for orthopedics or orthopedic procedures or general surgical procedures. That's an active discussion. I haven't heard anything about truncating training or creating hybrid pathways of, you know, general anesthesia and pediatric anesthesia combined in such a format. Anesthesia, there are a handful of combined programs with pediatrics. There's pediatric where you can get board certified in pediatrics and get board certified in anesthesiology and a combined 5-year program. Still requires to do a pediatric anesthesia fellowship after that. I think these are all things that are getting, discussed to see how we can expand our workforce. But really excellent thought, and people, at least at the pediatric anesthesia leadership level, are billing this very much a crisis and are looking at the lens to say in 10 years, what's going to happen? How are we going to be able to provide care for children? And looking at every single different option that they can think of right now.
Two questions in the chat. The first one was on CRNAs and AAs, and I think you kind of answered that earlier. The second question from Dr. Osley. I want to congratulate Sim and Amod and the anesthesia team on their recruitment success. It goes to show that people move for programs and leadership and not just for money.
So that's great to hear. Thank you, Dr. Osley.
And I have one question on a different thing. Okay, if you go back to 20 years of Phoenix Children's, there was a lot of sedation on the wards. And slowly that kind of eroded. And one of the biggest factors on that eroding was the anesthesiologist wanted the business. Now that the anesthesiologists are paid by Phoenix Children's, are you aware of any cost effectiveness on, having residents and hospitals do, sedation on the wards? Is that cheaper than sending patients downstairs and getting an anesthesiologist doing it? Or is it more expensive? Because there's a lot of factors that could make it either cheaper or more expensive.
So the question was, over the last 20 years, there's been more patients that are no longer receiving sedation on the floors and now are coming for anesthesia to have procedures done. And is there any cost benefit to reverting to another model where sedation is actually happening on the floors as opposed to in the operating procedural rooms?
Yes, if you have one employer paying all the things.
Under the guise of just a single employer as opposed to different practices all piecemeal together. And so to the first point, I will say that this is happening everywhere. Just no matter what the model is. 20 years ago, kids were having liver biopsies on the floor, a little betadine on the stomach, a little pump, a core needle, and you got a liver biopsy in there. No one, they laughed. You said you want to take the child to the operating room. I think many of our CCBD colleagues were doing, LPs and all of their patients in clinic 20, 25 years ago. And there's certainly been a greater push to provide comfort measures for our kids undergoing procedures with noxious stimuli. So to answer your first question, regardless of the payer model, I think there has been a much bigger push to get kids more comfortable and provide them with any degree of sedation or anesthesia for them to tolerate those procedures. Now, under the second question, under a single employer model, is there a difference? I can't tell you off the top of my head if there's a cost segregation analysis on how that is. I think, just going off of common sense, my guess is that we would probably be a more expensive service. In general, I think for a lot of our ICU kids, they either there's DRG billing, there's single diagnosis billing, and so whether an anesthesiologist provides it or intensivist or hospital, I don't think that changes the reimbursement to the hospital from the pro fees perspective. So I don't think that there's any. Oftentimes for our inpatients, as payers are going to a diagnosis related billing, for many of those times, there's probably not a difference in cost to the patient or the institution for that. Certainly for outpatient care, that may be different.